Well, welcome everyone. Good morning. My name's Scott. I'm one of the neurosurgeons here at Memorial Regional. I had spent a year with the department in 2018 to 2019 and had been around the department much earlier than that. So very humbling to have a chance to talk for a whole hour. It's actually my first Grand Rounds opportunity. I had been around the department as early as 2004, believe it or not, in some of the labs upstairs. So certainly a privilege to talk for about an hour or so. We'll talk about a topic that I had been interested in and had used this book, this Ames book, to finally put some puzzle pieces together. So we'll talk about this specifically. It's a wonderful book. There's 24 chapters. There's wonderful topics. We'll probably cover maybe half of them because there's a thread underlying all of this that I was putting together for myself, which really is the intention of the whole talk today, which is a bit of a catch-up scenario. I had been looking at this cervical spine deformity book, realizing that there's all types of data, all types of measurements, looking at the spine from head to toe. And I wanted to figure out, well, how can I play catch-up, knowing that our faculty and folks with more experience than myself, just getting started here, just see it on this screen. They know what to do. I mean, we're gonna look at three very similar cases. They're post-laminectomy or post-laminoplasty cases of mine that I'm sure faculty would say, oh, that's what we do. We cover the defect and realign them. But I wanted to understand, well, where's all the data coming from that we get preached about, not just talking about the lumbar parameters that we've heard most recently and probably more commonly, but how can I tie into my world all these cervical spinal parameters? And yes, we eventually have to talk about the thoracic spine and start figuring out thoracic kyphosis and trying to understand what this means and what it does and how it behaves. So I wanted to start with just imaging and be the best radiologist I could. My father would be proud. He's a radiologist. So I can rattle off all these numbers in my head and do it in 30 seconds. You can get a scoliosis film, you can do 10 parameters, and it's right there for you. And then you can start to see, these changes in these patients and get a better understanding of what the spine's up to. But also, I wanted to know, well, if I can do this and play catch up, well, then maybe I'll be more prepared for when the bigger cases come in, if they do come in. If there's a patient with the real chin on chest deformity or has 90 degrees, something catastrophic that has to get corrected, how can I still apply the same process and not be scared and not be too worried about the severity of what I see? So what's important today? Really not much. I wanted to just put that intention out there so we all have a good understanding moving forward, and then we'll show a couple cases. Dr. Yurkov and I have kept in touch. Very kind of him to share some of his films, because he had mentioned he had talked about this topic about a year ago, and he has said we went over the cervical spinal alignment numbers in his talk in July. You see there on the bottom right. I wanted to get past all that. I wanted to make sure we got to the very end of the topic and cover what the book had shed light on for me. So this is just a bit of review, just to know these four topics, starting from the bottom. Again, there's something for hopefully all age groups and experience groups here, just to talk about at the end in discussion. So from the beginning, cervical lordosis, I think we have a very good understanding of what that is. It's the amount of lordotic curvature in the spine. It's measured from the C2 end plate to the C7 end plate inferiorly. Normative values are around 10 or negative 10 by nomenclature, but they can range to 10 plus or minus that figure. The number in my head is negative 10. The next parameter is cervical sagittal vertical axis, C2 to C7. That's considered a classic measurement of sagittal alignment of the cervical spine. It's measured as the distance from a plumb line just straight down from C2, and then measuring the back of C7 to find out what that number is. Normative values of that metric have been around 0.5 to 2.5. And there's some studies out there with regression analysis. You see the R value. It's a best fit understanding as all this data is, suggesting that if it's around 4 centimeters or more, people are suffering. They're having disability on their patient-reported outcomes. Chin-brow vertical angle, very simple, very intuitive. You want to look forward. All patients do. What should it be? It should be around 0. But there's numbers that would suggest if you correct them after surgery to in and around 0, plus or minus 5 or even 10, they'll do okay because they can compensate. There's such extension and flexion, especially with the upper cervical spinal levels. And then the last one to talk about is T1 slope, which is defined as the angle very similar to a sacral slope. So the intuition's still there. Sacral slope is the slope of the sacral body from the horizon. T1 is the same, and the number there is around 40. If the angle is above 40, it can be associated with worse patient-reported health outcomes. Just to touch on the alignment, this is a broad slide from Timmer. The range of motion of the cervical spine is pretty impressive. You have nearly 90 degrees of flexion, 70 of extension. I wanted to highlight just two figures, especially when you're planning for surgeries. Even a simple C1-2 fusion can really take out a lot of motion. Even if it's a single level, you're losing potentially 40 degrees, as this slide suggests. You're losing 40 degrees of rotation. And if you do an OC fusion or anything more, the extension that you find at the OC1 level is pretty significant. That's 20 degrees. So I keep in my head OC1 is involved predominantly for extension, and then C1-2 is for rotation. And then lastly, a couple other numbers here, basic older information. Everything else in the subaxial spine can be considered a few degrees. We talk a few degrees are lost on a single level anterior cervical discectomy, but they can add up over time. These are some standard figures from a study measuring cervical alignment in patients without any neck symptoms whatsoever. It's an older study from Spine from 1997. Everything in the subaxial spine here. So if you look down here at these numbers, they're all a few degrees, 2 degrees to 4 or 5 degrees. I would be curious to see what people say. I would say, any patients that have a single level fusion or disc fusion anteriorly, they're going to lose maybe 3 to 5 degrees. And then lastly, trying to go from the cervical spinal alignment, the lumbar parameters, the lumbopelvic parameters, and then filling in the middle. I think we've touched on these plenty of times in previous talks. They're all listed here on the left. Sacral slope, it's a similar angle across the horizon. Pelvic incidence is considered a fixed parameter. It's a part of who you are for the patient. That's measured between the femoral heads and the midpoint of the sacral body, and then another perpendicular line off the end plate. And that gets an idea of the pelvic alignment. And then pelvic tilt is a measure of compensation. It's considered an angle drawn vertical from the femoral heads down and then across to the midpoint of the sacrum. And this can rotate over time. Those normative values are 10 to 15, and then anything over 20 to 25 is when you start to see disability reported in patient outcomes. And you see this classic figure off to it's a little cut off on my screen, but the classic figure where patients start to bend their knees and flex their hips and rotate their pelvis back in an effort to keep them in that cone of economy, that Dubochet cone of economy, or be in harmony. There's the standard geometric equation, lordosis, I think we've touched on, which is a metric from L1 to S1. That's ranging around 45 to 55, but can vary by another 10 degrees. And then SVA, the sagittal vertical axis, from C7 down in a plumb line, and the equation for mismatch. The SVA for the lumbopelvic parameters is very similar to the SVA in the cervical spine. It should be around 2. But if it's greater than 50 millimeters, it can be associated with disability scores and back pain. The pelvic parameters, I'm sure we've described that: mismatch plus or minus 9, plus or minus 10. So here's the next step. We're going to punch through and talk about thoracic kyphosis. There's even another book that I've been very lucky to find. This is a book that's almost 20 years old, from the Spinal Deformity Study Group. They were measuring T2 to T12, T5 to T12. Now here we're talking about in this book, T4 to T12. And I was wondering, this is really variable. What's the problem? But you're looking at a film, you can't even see it because of the shoulder opacity. And I figured that's the most common and basic reason for that. T4 is pretty easily visible on standing scoliosis x-rays. And those normative values, according to this book, were around 40. But the interesting thing is, what's interesting is that we've already been really incorporating and dealing with thoracic kyphosis all along, since we're drawing a C7 plumb line and doing a sagittal vertical axis and just looking at that and seeing where the S1 body, we're already dealing with thoracic kyphosis in some certain way. So I've said at the bottom, it is related to the pelvic parameters and vice versa. We've never just necessarily, touched on that in that fashion. So going from a global alignment to the cervical alignment, these are the numbers. Cervical lordosis around -10, SVA is around +15 millimeters. The chin brow vertical angle should be around 0. T1 slope around 30 or less, and then a mismatch parameter based on a previous study from 2013, cervical spinal alignment and deformity. They had tried to make an analogous argument suggesting that a slope and the lordosis should be no different than about 20 degrees, or else there can be also associations with disability. There's going to be 2 more things, and then we'll talk about the rest. This is part of the book that I thought was some of the newer information: the cervical thoracic angle, the junction. This is an angle that they've talked about describing both lordotic segments of the lower spine and kyphotic segments of the upper thoracic spine. And they considered normal values of the cervical thoracic angle from the upper end plate of 6 to the lower end plate of T4. And those have been reported around 5 degrees of kyphosis. But this can also increase over time, which means as every decade goes past, they can gain a few degrees, probably about 5 degrees each decade. It can go up to 20 to 25 degrees over time. So it is a mobile and changing variable, but it's a way to measure the junction so that we can have an idea of where deformities are. Is it in the subaxial spine? Is it a junctional issue? Is it thoracic spine or below? There we go. So this is going to be the first piece of interpretation that I thought was interesting. This is in a chapter dedicated to identifying where the apex of the deformity is. They were using 2 metrics just as a screening tool. There's another way to do screening tool, kind of a quick and dirty way to look at the spine to see where the deformity lies. Here we're comparing 4 different scenarios of the cervical thoracic junction. First of all, we're admitting to ourselves, yes, we're going to start measuring this to identify where deformities are in general. And then 2, we're going to try to make a comparison to say, okay, let's drill down and really identify which in particular level this problem may be at. So we'll start in the upper left here, and then we'll work our way clockwise. And the comparisons is a very 2x2 box plot to suggest where it's at. It's either above or below. With a normal, so you see this patient standing and they're forward here. If they have a normal thoracic slope, which could be indicative of normal thoracic alignment and posture, and a normal cervical thoracic junction, their junction is standard amount of kyphosis, 5 degrees, but they're very far forward. This would suggest, as the star is placed here, the deformity would be in the cervical spine or the subaxial spine. Over here, when you're looking at a normal thoracic T1 slope and then a kyphotic angle, you would imagine that you have a thoracic problem, particularly in the upper thoracic here, and you check the junction specifically from C7 to T4 to see where the deformity is. Going over here, if you have an increased slope, this T1 body is tilted very far forward. It's already tilted far forward from everything below it, and the angle of the junction is additionally kyphotic, then there could be a deformity in the upper thoracic spine, which they defined as T1 to T5, which would imply you're not actually seeing anything here on this film the way it's shown. You need to go look elsewhere, go look at the scoliosis films or the standing thoracic films. And then lastly, if the slope is high, T1 is tilted very far forward, but this angle is normal, it's suggesting that the whole half of the upper thoracic spine is actually quite normally arranged. Something is very far lower, much lower below it to identify a deformity. And they say if the thoracic kyphosis in general is normal, you should look even in the lumbar spine for the deformity, meaning they still have 40 degrees of kyphosis here that you just can't see. If the thoracic kyphosis is high, then you should look in the lower half of the thoracic spine to see if there's a deformity located there. So this is one way to just do a bit of a comparison. We're starting to use 2 of these angles to start identifying. And when you see the scoliosis films, you'll see it all at once. So it's not as stopgap as a process to start looking at these things. It'll be a quick flash and it's seen all at once. Another quick, kind of quick and dirty way to look at the spine when it's standing with scoliosis x-rays is using these two metrics. One's considered a C2 slope. It's a very analogous measurement to the T1 slope. And you're comparing that to the T1 slope, and there's just a either or situation to figure out where the deformity may lie. So here's 3 examples that we can just run through very quickly, and it'll tell us a better idea where something may be awry. So if the patient has a high C2 slope, which means this C2 body is tilted down already, and their T1 body's in a standard position at 30 degrees or less, it's suggesting that what's in between and the subaxial spine has failed the patient and there's a deformity in this location. Take a look here. If the patient has a low C2 slope, this angle of C2 and the rest of the upper cervical spine appear to be normally aligned. However, this angle is very, very high. It's suggesting that something in the thoracolumbar spine is awry and look elsewhere, as opposed to looking at the cervical spine. And then in the other scenario, a higher T2 slope, their angle is much higher. They're already facing forward and inferiorly, and there's a high T1 slope. There could be a cervical and thoracolumbar, so look everywhere. So it's just a quick and easy way to take a look at the spine, measuring 2 different variables altogether, and then identifying where we think the issues are. And then this should be the last piece of new information. Then honestly, that's it. We've covered all these extra parameters, including the thoracic spine that we've touched on. There's something called a thoracic inlet angle. And this is, not really that well understood from what I've interpreted in the book. They're applying it as a fixed parameter. It's considered a bony circle without range of motion, and it involves the T1 body and also the first ribs and the sternum. So they consider it a fixed parameter, and it shouldn't be changed with age. It can be altered by changes in thoracic kyphosis, however, and it's normally seen in a range of 70 to 80 degrees. And they are suggesting in these chapters that if osteotomies are considered in the upper thoracic spine, so you've looked at the spine, you're thinking it's cervical, you're thinking it's thoracic, maybe it's in the upper thoracic spine, or I need to do work there. Okay, I'll check this angle, see what it may suggest. If it's very, very high and the angle of the junction is very kyphotic, well, then that would be confirmatory to suggest, hey, I have deformities located in the upper thoracic spine. Oop, there we go. There's a nice chapter on physical exam findings. I didn't find much different here. Just to show you a couple examples, there's a picture on the left that shows patients in 2 different postures. I started doing that more commonly now. I thought that was a great idea. You ask patients to relax and their head will go down because they're trying to show off and their head's too high. Or you can back them up against a wall and you can see what that gap is. I thought that was quite interesting, just basic physical exam findings to see how patients are. And then you can get a measurement for yourself. The middle picture shows 70 degrees of a positive chin-brow vertical angle, quite dramatic. And then something that Timur had touched on the left, this Benzel sign or trapezius hypertrophy due to the deformity. The body is trying to rear itself back onto its thoracic outlet in an effort, and these muscles hypertrophy over time. Okay, let's talk about osteotomies and surgical techniques, which I know we've seen in the previous presentation, but I found a different way to organize it for myself. I wanted to share that with everybody. So there's an Ames deformity classification for cervical spine osteotomies. It's analogous to the Schwab classification, grades 1 through 6. It's also analogous to the eponyms of Pontes and Smith-Peets and these things. And they're all overlaying each other, grades 1, 2, 3, 4, etc. So I was going to march through that with everybody and then group it, and then it's kind of display how we use these tools for surgery, at least the way I had recognized that. Off to the left, you have an example of a grade 1 osteotomy, which is a basic anterior cervical discectomy, or if you're doing it in the back, you're disrupting and loosening these facet and lateral mass joint complexes. Grade 2 is considered laminectomies with fuller osteotomies, where you remove the whole joint. That kind of sounds similar like a Ponte osteotomy in the lumbar spine. You have to do a bit of a laminectomy to get there in the first place, and then you take off the SAPs and the IAPs. Grade 3 is considered a corpectomy. That's also somewhat analogous to a corpectomy in the lumbar spine. And then here's where it gets a little bit interesting. It's actually quite different. A grade 4 osteotomy is when you have a full disarticulation, where they take out the unstenotic processes on both sides. Yeah. I've never done that. I've never seen that. You'd have to navigate the vertebral artery and all those venous plexuses, and I can imagine that's quite destabilizing, and maybe used more so for rigid deformities where the spine just isn't flexible. And then grades 5, 6, and 7, we'll just not talk about them. They're all much more severe and dramatic osteotomies. You do it from the front with a grade 5, where you're pivoting on the middle column. A grade 6 is just like a PSO, where you're taking down the entire posterior and part of the middle and then compressing it. And then grade 7 is a full vertebrectomy. So I'll go back and forth here. Grades 1 and 2 are typical ACDS or LAMIs with the full joint resection, and then a grade 3 is a corpectomy. And then you go further and say, okay, well, the lumbar spine, pardon me, the cervical spine is either flexible or not flexible. Well, all the disc work that we do, or body work for corpectomy, is grades 1, 2, and 3. These are all the common tools that we use anyways. It's just they're being classified as grades for common nomenclature. And then the ones in red are osteotomies for rigid deformities, meaning that the spine doesn't move on flexion extension. You have no discs to use. You have no joints that are mobile. You have to do bone work. Grade 4, they've described, pardon me, they've described as an intermediate type grade that can be used either for flexible or rigid deformities. So the takeaway here, as I flash back and forth here, is all the standard stuff we've been doing and being used to and trained to do from the beginning. That's all the grades 1 through 3, bread and butter disc work and joint work that helps mobilize the spine when it's flexible. And there's rigid deformity osteotomies for more severe cases. The last chapter, before I show off some of these cases, is the 24th chapter, an assessment of surgical treatment strategies for moderate and severe deformity in the variations of approach. And what they did was they pulled 14 deformity surgeons, orthopedic and neurosurgery surgeons, and asked them what their surgical plans were. And there was about 25 plans, from the least complex deformities being just like we're going to look here, the kind of starter cases, a cervical post-laminectomy or mid-cervical spine deformity versus more complex ones. There was complete lack of agreement between even the simplest or the complex cases, meaning that in the simplest of cases, people were 50-50, saying, oh, I'd go from the front, I'd go from the back, I'll address these things. I know where the apex is, but I'd still do it either or. And then as the deformity also got more severe and marched down the spine into the junction, into the thoracic spine, more and more people were suggesting they would do a posterior approach, but there was still quite significant variability. So that didn't help, but it confirmed me the point that you really have to kind of tailor these as best as possible to every patient. My takeaways from this were look everywhere anyways, because we're getting used to looking at scoliosis x-rays and flexion extension films, and then look for dramatic numbers, not necessarily specific numbers, but try to find that normative value and see what may be an outlier. You know, all of a sudden there's 7 degrees of thoracic kyphosis. What's going on here? And let me see if there's, you know, something that's associated with that. And if I can figure out if there's too much thoracic kyphosis or too much lordosis, there may be a higher risk of junctional failures that I should be worried about. One thing they did say was, don't stop at C7. That was somewhat pretty definitively stamped out in some of the papers and literature they quoted. I remember from our training in USF, we've always talked about when Dr. David Cahill was around. I've never met him. He was a big proponent of going to T1. He had that knowledge even back then, 20 years ago, but we were only told what to do. There's a 2.3 or even higher chance of revision versus going to T1 in the reported articles, and there's a significantly higher incidence of junctional failure at C7 if you don't stop at T1. And that's probably intuitive knowledge from 25 years ago that we're trained as standard practice today, in my opinion. And then be aware of any 360 plans, front back plans, or use of osteotomies. There has to be a justification for going front and back. I think it's nice to think about that and debate that with the patient, or even dictate that, the discussion regarding surgical technique, and put that in the operative note, because they do talk about that, and they say, hey, that helps you justify your planning when the things aren't so clear and there is variability, especially with the use of osteotomies. There can be a much higher risk of junctional failure or pseudoarthrosis at the top or the bottom of the construct. And then lastly, just to show you how complex it can be, there's two pictures that they displayed in this last chapter. They're both 70-year-old individuals. They both had cervical 3 to 6 fusions. They both had myelopathy, and they had previous deformity. Of course, the picture as an example on the left had failure, with risk factors for failure being listed as a transition rod or use of multiple posterior osteotomies. The pictures on the right, very similar preoperatively or between the first and second operations, with a cervical 3 to 6 decompression and fusion. And then the patient went on to have an additional laminectomy and instrumentation, and had great improvement in her spinal alignment. So just two pictures to make it even more gray. So how do I try to put it all together? Here's the 3 topics that we talked about. Or before we get to that, I'll show you, this is how I've tried to make an assessment of all the stuff that we've talked about thus far, checking all the measurements, trying to understand all these numbers and get better with that, and writing them down on a worksheet. It really can be done within 30 to 60 seconds. I think we'd all agree that we have to find the apex of the deformity, and find out the level or 2 levels where it is most contributory towards the numbers that you're looking at, and you identify that as the location. And then somehow, and I've taken this away from training from Dr. Uribe with his lumbar spine corrections and doing ligament releases, but somehow calculate the missing degrees that you need, saying this patient doesn't have this number of something. Checking flexion extension x-rays is paramount. That's done, I believe, as a commonality now. And then you're figuring out the connection. How do I go from a number of degrees, the imaging data, I've sped through the process, I'm head to toe with numbers. What tools do I pick, and how do I divide that across this patient and maximize the benefit with the least amount of footprint and hopefully least amount of risk? So I wanted to lay that out visually, and I kept that up in a few of the slides as we move forward. So this is going to be the first example. This is going to be a 67-year-old male. He has no osteoporosis. He had a surgery almost 10 years ago. He had a 3 to 7 cervical laminoplasty. He's had a history of a tracheostomy and has a bit of a raspy voice anyways. And he has severe neck pain. He can't look upright. He's very upset. He's in significant intractable pain, and he's failed all of his conservative measures whatsoever: physical therapy, stretching exercises, injections, etc. And he can't live like this. So he comes to the office. We do a physical exam like we've looked here. He has, he's looking down. He has that chin brow angle that looks somewhat dramatic. He's non-focal. There's no signs of myelopathy, and he has a tense neck. The imaging is showing that he's pretty arthritic and immobile. It looks like he has diffuse ossification on these films. And the flexion extension that was done here, I didn't show it here just for the sake of time. Nothing moves. There's no flexion extension motion whatsoever. So he's actually quite rigid, even though he's never had fusion. And he's had a laminoplasty about 10 years ago. So I'm going to click through these one by one, and we'll talk about it slow, and then we'll process the last 2 a little quicker. But this is the process I wanted to display for everyone, for all levels of experience, and trying to tie all this together. Going into the lumbar spine, it's all in yellow here, which is just pointing and clicking and doing angles on a PAC system. That's I'm sure everyone's fairly comfortable doing that. The cervical lordosis, everything's seen in yellow here, is 15 degrees. He's probably 25 degrees positive there already. His SVA in the cervical spine is very far forward. We said that should be around 4 or less. He's 70. His chin brow is low. He's looking down by 37 degrees. His T1 slope is very, very high. It's somewhat analogous to T2 slope, but it's very, very high here. He has a thoracic, let's just call it a junctional angle of positive 24, and his kyphosis is quite low, or within the low normative range of 27. So trying to tie all this together, there's a quick comparison between the slope and the lordosis as just a quick check. These are all, these three things in blue are little checks. So this suggests that he has a deformity in the cervical spine. He's mismatched. This should be 20 or less, and it's not. And then when you check his slope versus his junctional angle, his T1 slope is 38. His junctional angle is 24. So it suggests that the T1 slope is a little bit high. He's a little forward on his sagittal vertical axis, like we've talked about. And then we check his lumbar parameters. His lordosis is 40, it's somewhat normal. His PI is 56. He's tilting back a little bit, but when you give him a mismatch and give him a few extra degrees, given his age and so on, he's relatively matched in the lumbar spine on his parameters. What's more outstanding, right? We're trying to look for egregious numbers, is that he's looking down. He has no lordosis, and he's kyphotic, at least through the junction or even into the junction. Those are my takeaways. So what do? Step one's done. We said, let's calculate all the parameters. We do it in 30, 60 seconds. Number two, let's locate and try to identify where we're going to say this is at the deformity. We're going to say it's in the junction or it's in the lower subaxial spine, which also makes sense intuitively because he's had a laminoplasty, he filled below. That's what faculty would say with all their experience. They'd say, oh, just do this. But the kicker for me is, how do I figure out how many degrees he's lost? And then what do I plug in my head to pick and choose a surgery and then justify every particular level? Well, he's off 20 degrees based on his lordosis, at least. He is missing about 27 degrees from his chin-brow vertical angle. It should be, and we're giving him 10 degrees. And then his junctional angle would suggest that he's missing 18 degrees there. So if you average all these things together, you're thinking he's right around 20 degrees that he's missing. He needs at least 20 degrees. So this is the breakdown. I said he needs about 20 degrees on average. We're gonna pick and choose from our tools. Remember, he's quite rigid, and we're gonna have to cover the surgical defect and then do the realignment. So I said, well, let's take down the laminoplasty, take the autograft, and use that later by doing a laminectomy, and then do a partial T1 laminectomy, and then also try to get in these facet joints and disrupt them. Remember, that's a kind of a grade 1 type technique, trying to loosen up the joints posteriorly. It didn't work. He's very rigid. But in the moment, I'm trying to avoid these rigid deformity techniques. I was hoping to combine these and avoid the more severe risks that are associated with those. So I said, with my hands, and this is probably in particular for everyone, but this is a great point of discussion, what people remember in their heads of what they can get with their technique. You know, I get 10 degrees with a Ponte, I get 5 degrees with Smith-Peets or grade 1s and so on, or 30 degrees with a PSO. I had admitted that even though we're trying to loosen him up, he's very rigid, and with the history of tracheostomy, there's nothing that can be done from the front. He's rigid anyways. Those discectomies from the front are for flexible deformities. That's not going to work. However, I don't want to do a larger surgery with larger grades associated here on the right. So I said, okay, we'll do a surgery just below the subaxial spine at C7 and T1 and do that grade 2 type of full resection of the joint, or Ponte osteotomy. That should be at 2 levels because everything else doesn't move at all anyways. And then we get the correction, hopefully, that we need. Maybe I'll get 5 degrees out of each of those, and then that should cover the 20 degrees. And then covering the previous surgical defect and building the construct, you can hopefully see I had chose to do a lateral mass at 3 and 4 to have 2 points of fixation at the top. And because there's osteotomies at the lower part of the construct, I had chosen to do 2 points of fixation below the osteotomy, and that's consistent with what's also been written in the text. So here's the correction that hopefully you can see the difference right there. There's the difference. And then here's the numbers. His lordosis is -3. It's much better. He's right around 40 millimeters there. He's facing forward. The C2 slope improved significantly. It was 50 over to the left. Now it's 28, nice in the green. And then his sagittal vertical axis improved significantly. So that seems to be a bit of improvement. He's very happy. His upright gaze is right around 0 degrees. And that would tell me in hindsight, yes, you accomplished, and you got about 20 degrees that you needed. We'll go through another one here for a different reason. This is a younger gentleman. He is 37 and he had a neck injury a few years ago. So that's why you see some old hardware here. It's at cervical 5 and 6, I believe. He had a spine infection and came with a kyphotic deformity and severe intractable pain. This is his MR T2 just to show the inflammatory changes, but had contrast enhancement throughout. He had disruption of his interspinous ligaments, as well as infected previous hardware, as well as a pretty significant Schmall's node at the C5 body, and then involvement of 2 other bodies below it. So he's nearly got a 360-degree infection with a deformity and splaying of these spinous processes. But unfortunately had a great motor examination, which is severely myelopathic. So the numbers here again, he's severely positive on his lordosis. He should be -10. He's missing 35 degrees. His SVA is around 4. He's trying to compensate, I'm sure. The chin brow angle wasn't that reliable because the technique wasn't done that well on the x-rays with the technician, so I had to scratch that. And you can go through these numbers and see the slope is a little high. He's a little kyphotic through the junction. His thoracic kyphosis is very straight. So that's a red flag right there. He must be compensating with this thoracic kyphosis. He's trying to straighten out his back in order to stand up straight. And that T1 slope is actually within a normal range. So that tells me that he has a subaxial problem and he's compensating throughout the thoracic spine. And then skipping to the pelvic parameters, you see that those are pretty within range. Just move this marker here for myself 1 second. And he wasn't mismatched at all. So moving forward through this case, step 1 is done. We checked all of our measurements. I think finding the deformity is pretty easy. He's got an anterior infection with a kyphus at C567. But how many degrees are we missing? We sum up the egregious ones. The lordosis would suggest we're missing 35. The chin brow angle is unreliable, so you have to toss that out. I picked the CTA, that junctional angle. It should be only kyphotic by about 5 degrees, but he's got 25 degrees of kyphosis across the junction. So I had said, let's pick a number around 25 degrees, or pardon me, 30 degrees that we need, and then pick our surgical tools. Well, number 1, he had an infection in the back. That's got to come out. Number 2, he's got infection in the front, which is the apex of the deformity. That has to be addressed. And it's a flexible deformity because he's a young gentleman. We assume that. I don't think I got flexion extension films. I didn't want to flex and extend him with that image on MR. But under the assumption he's young and flexible, I said, okay, that's another affirmation. He needs to have the surgery from the front. And then in the back, what else is lacking to accomplish the number of degrees that I should get? So I had involved a multi-level corpectomy. I said that should get me 20 degrees. That would be over here as a grade 3 flexible osteotomy, just as reference. And then the remainder should hopefully come with 1 osteotomy at C7. And then the laminectomy through 6 and 7 as well, and then reduction of that intraoperatively, and then performing the rest of the surgery with the instrumentation, covering the corpectomy to C3, and then instrumenting down to T2 to cover the osteotomy by two different levels. Here's the result here, which looks like a lot, but he had about 40 degrees that he was missing, and I had used fibular allograft up front just to decrease the metal burden as well. And then his numbers all in green on the right. He's -6. His SVA in the cervical spine improved significantly from 47 to 17. There's another metric that you got your 30 degrees, hopefully. His C2 slope is 13. It was 37, somewhat suggestive of around 25 degrees or so. and then so on down the road. And you can hopefully see that blue line, he's nicely lined up. The thoracic kyphosis actually went to 30, which means he kind of relaxed. He's not trying to stretch that spine out so straight, even to the point to where he was even retroverting his entire upper back, you could suggest, and see how negative this SVA is versus it being right on point after surgery. And then lastly, we'll go through this just to show you the complication and how I addressed it. This is a gal that's also in her mid-60s. She had a previous laminectomy from 3 to 6 for spondylotic myelopathy. She had a kyphotic deformity. It's a bit hard to see, but she's kyphotic across her surgery, and she also had her hardware pull out at C3 on C4. This was done about 8 years ago, and she had sustained a fall about a year ago, and had intractable neck pain at that time. Luckily, no myelopathy. And you see her parameters here. She's very far forward on her lordosis. Her SVA is right at the borderline. She's compensating and looking forward. Her C2 slope is actually forward. And her thoracic kyphosis is somewhat low. Maybe she's compensating just like the last patient, and that T1 slope is 10. So identifying where the issue is, it's in the subaxial spine. Her lumbar parameters look fine as well. And then after surgery, which was a removal of hardware and then performing an osteotomy below, trying to loosen these joints up as well in a grade 1 fashion, I had instrumented 2 points above the old hardware, going to C2, so I have 2 new points of fixation, and then with the osteotomy below, went to T2, I believe, and got a decent correction with the lordosis and the SVA, and getting that junction down a little bit as well. But this is what happens when, well, actually, before I say that, this is just the breakdown. I thought I needed about 25 degrees. After taking out the old hardware and replacing it with some new points of fixation, there's a small laminectomy at the bottom and with the osteotomy, and then I tried to loosen up these facet joints in a grade 1 fashion, didn't work that well, and then went from C2 to T2 to have points of fixation above and below for about 25 degrees. So this is what happened. Had a wonderful surgery for about 4 months. She was doing excellent and had no pain. And then all of a sudden the hardware pulls out. So I said, okay, well, she had a transitional rod. Maybe that contributes to it, but I haven't looked in that enough yet. She had a flexible level that I failed to identify, 3, 4, and 5. This is C4, 5. This was flexible on her flexion extension that we did. And probably I didn't have 2 points of fixation. I probably only had 1 good point of fixation at the cervical 2 level. She had previous hardware. I had replaced and extended screws, probably only 1 point of fixation. But I think what stood out is the flexibility of this level at C4 on 5. This moved a lot, and maybe was the cause of her first initial hardware fail out, even though she had a fall. So we addressed it. She initially didn't want any anterior surgery whatsoever. I spoke about that up front. And as a solution, we had to go back. We removed the rod and the 2 pairs of screws that did pull out. And buttoned that up quite quickly. And then under the same setting of anesthesia, went back and used this specific cage just to address a single level at the flexible point and get it fixed. One of the things I'd taken away is if there's any flexibility to the spine, you've got to address it. That's actually to your advantage, or it could be come to haunt you, because it is a flexible point and we're trying to instrument and get that gone in general. So the flexibility of any level is actually to your advantage if you can plan it in advance. Oops, sorry about that. So I had felt that was the case. We did a hyperlordotic cage to capture as much as I could. We did a standalone to save time, and then went back and re-instrumented C2 with navigation so I could get a better point of fixation and put a navigated pedicle screw in there. Last thing to touch on, but for the sake of time, we're going to pass it up. There's a frailty index and frailty scales out there. It dates back to 25, 30 years. There's an article, there's initial scales from the Canada Health Services called the Clinical Frailty Scale with lots of figures here. You can see people 1 through 9, they're around 4, and they start to use walking assistance. And this is seeped into the spinal literature using an Edmonton scale for geriatric medicine, trying to see if they're frail or not, quote unquote. even the concepts of frailty, the way it's defined is variable, but the goal is to identify patients at risk for failure in any way. And there's an adult deformity score in the neurosurgical focus from 2017. That was for adult spinal deformity. That's been applied to the cervical spinal deformity literature. That's why it's in this book this time around. And they've concluded under both scenarios that, despite the use of 40 metrics to figure it out, we're not going to do this on our own right now at the bedside in clinic. It's too burdensome, but maybe an app one day or AI. That patients, if they are frail, they are at risk for having major complications, and it should be used as a bit of a screening tool, and hopefully that can be even put in as an app one day or into our Epic systems. So here we go. To wrap it up, in discussion, what I've learned, I've crossed over, and we're looking at the thoracic numbers and trying to go head to toe on all the data we can, trying to play catch up and get that intuition that senior spine surgeons just see it and they know what to do automatically. But now we can prove it because the data is not going to go anywhere. I've gotten used to evaluating the junction. I'm going to hopefully start checking on frailty, and don't forget about that flexibility. That flexibility can come and haunt you. This has been my goal the whole time, is to get this low-hanging fruit and get the process down, not necessarily figure out how to do post-laminectomy syndrome 3 times in a row. So when the big case comes in, if there's 90 degrees or more, 70 degrees or so on, you can get that process down and still apply those basic rules and hopefully get the results that you'd be looking for. So in conclusion, yes, I've quickly tried to digest this information because of this book. This book has been an excellent tool. I definitely recommend it. The planning has been enjoyable. My radiologist father would be proud looking at films and trying to get the speed with that. And I hope, fingers crossed, that I'm better prepared for some cases when they do show up. Thank you so much.
Scott, so you apply the frailty index to all your patients that are kind of questionable?
I not yet. No, I need to, and I should probably develop a worksheet and have it in there as a screening tool. I want to, but I haven't started yet. I have to probably start picking and choosing how I'm going to start measuring that, and then just see what it shows. But the answer is no, not yet. It is definitely coming.
Absolutely. Okay. All right, guys, I appreciate your patience and attention, and I can sort of see a few of you over to the right, but this is a kind of interactive little talk, and I'm not sure it'll go the entire hour, but I want it to be something that's interesting for you. All of the patients that I'm going to talk about are actually your patients, and the topic is near and dear. I'm going to talk a little bit about neuroprognostication and how we approach it, and what maybe some future insights to it are. I don't have any relevant disclosures for this talk. We're going to talk a little bit about the issue, the problems with neuroprognostication, what traditional and maybe newer approaches are, some research that we're doing that I think is super cool. And then I have some cases to run for you. So and then I'm gonna ask you your opinions. So I guess we can do raise of hands, or somebody can speak up, or I don't know, I'll try and call on the residents if I can find you guys in the list. Okay, so I'm gonna start with a little bit about this guy. So most of you guys know him. I had the great privilege to work with Ross for, I think, 11 years here. And I was a little starstruck when I came, because I met Ross at a meeting when I was a fellow, and I was like really in awe of the work that he had done, and I thought he was just this larger than life person, and I was right. He is an amazing clinician and a great person. And I remember coming to Miami after I had been an attending for about 6 years and rounding with him. And he was pretty far into his career at that point. And I remember a woman asked about her son's prognosis, a TBI patient. And I remember he said, well, I'm not sure, but I think it's probably going to be okay. And he just really, he gave a very like, open kind of prognosis for this kid. And I remember thinking, oh my God, if he doesn't know, then nobody knows. And why doesn't he know? Because there's so many young junior, attendings or residents that say they know exactly how somebody's going to do, right? And I just remember being kind of a little disappointed and a little confused and sort of like, if anybody should know how somebody's going to do, it'll be this guy. And why isn't he saying he knows this? And then as I've gotten older and as we've started to look at these things, I understand that that's actually a very, very experienced answer. And that sometimes the more you take care of these people and the more you see their varied outcomes, the more you realize that there's a lot we don't know about neuroprognostication. There's many things that we don't do well. And there's many things that we are still trying to find out how to do better to get a handle on this stuff. So we have patients all in our unit with acute brain injury. It's a very common problem. The patients that we see that many of them are most severely affected are traumatic brain injury and intracranial hemorrhage and subarachnoid hemorrhage patients. Many of these patients with acute brain injury are initially comatose. And prognostication is the most difficult in these patients, and it's also the most critical. These are the patients that you're trying to figure out, do you trach and peg them? What do you tell their family to expect? Should we continue aggressive treatment? Do they deserve to be in an ICU bed and stay in an ICU bed for however long it takes to get them through their acute course? Is that a good allocation of resources? What if they're 90 years old? What if they're 20 years old? What if they have brainstem involvement? What if they have cranial nerve involvement? What if they don't? What if their imaging is good? What if they have comorbidities, right? These are all things that we kind of in the background process as we're trying to come up with prognoses to help the families. And prognostication is important. Like I think that it's super important that we have a good relationship with the family to let them know that we have some idea of what's coming next, and that is obviously very comforting for the family. They don't want us to say, well, I have no idea, I guess we'll see how it goes. But on the other hand, I think we do need to realize that sometimes these prognoses are very difficult to decide.
Hey, Christy,
yeah.
I was just going to say, I know this is a TBI talk, but I was just going to put in a plug for SCI because we kind of go through those same, angst, and we're actually talking to the patient, not necessarily the family.
Right.
And that's why they call it prognostication, because you don't know, you just have kind of an idea. But I can tell you, there's one thing that you can never, ever, ever say to a family when a patient comes in with a spinal cord injury, or the patient, is that you will never walk again. And the reason is, you might be right. More importantly, you might be wrong. But either way, they will always remember that doctor who came into the room and said, I will never walk again. And they will, that is the thing they will remember and despise for the rest of their life.
Right.
So
absolutely. That will poison the water forever. And so I totally agree with you. And I think that the same is true for acute brain injury. I think we don't know the whole story, and you have to leave a little bit of room for the possibility that people are going to do better than you expect. And it really undermines the family's belief and trust in you if they feel like you've closed that door prematurely. And so I don't want you to think that I don't think that we should give people an expectation of what's to come. I think it's really important, and I think they need that guidance from us. But I just want to recognize that this is a very difficult thing to do. It's not simple. It's not straightforward. And it's very important in this period because you're deciding aggressive versus conservative approaches. Do we do we resuscitate this person? Do we operate on them? Should they get an EVD? You know, do you do a trach and peg? And then also you need to have people have reasonable expectations as well, right? So you got to manage the family's expectations. You can't just be all rainbows and sunshine, and then have the family be blindsided at 3 months when they have a patient that's dependent and very disabled, or a year. You know, and so that it's sort of a really difficult gray area to walk in. So experience and expert opinion has sort of been how we come up with prognostication. And that was sort of my little anecdote with Ross was, you know, he's the beacon of experience and expert opinion and at that point. And so a lot of times that's how we decide what we're going to tell families. And then I will say that it is probably a reasonable and valid way to give guidance, but I will also say that it is not 100%, and we don't always know, based on our past experience, what's going to happen with the patient that's sitting in front of us. And then there's like the young ones. This is from Scrubs. I don't know if anybody's ever seen that, but this is, you know, somebody who's fresh out of school and they read the book and they think that they know, you know, what's going to happen. And then they say with absolute certainty, your son will never, you know, walk again, like Alan was saying. You know, I think, and that's the other side of the pitfall, right? So you have to somehow navigate these two forces. So we got interested in I mean, we've been interested in prognosis for a long time. This was, I found these slides. This was from 2017. We did some work in our unit with Ron and Simon, and then Ken Goodman from ethics. And it started off because we had a bed problem, and we were having to triage our ICU beds, and it's still a problem even in our bigger unit. But we asked ourselves, are these beds being taken by people who have an outcome? And, you know, is there a better way of looking at who should be in these beds and how much time and money they take? And I think that the project came from a good place. I think it really came from, you know, wanting to do the best we could for the people who needed it the most. And the idea is this is Ramsey's curve. It is a conceptual idea of everybody in their life has a birth and a death. It doesn't matter if you're a preemie baby that lives, you know, 10 minutes, or if you live 105 years, you know, and have a really long life. You have a birth, a death, and at some point you have the Z point where it's kind of downhill from here. And the idea is that once you're beyond that Z point, the things that you do are probably not going to reverse your process towards death. And the idea of at some point you shift from trying to reverse pathology or illness, and you really need to provide comfort and the best possible death you know, that they can have. And finding that Z point is difficult, or knowing when you're there is a tricky thing. And so we were trying to figure out, you know, what are the things that we can do to try to understand who we should be maybe focusing on comfort instead of aggressive treatment. And so we were thinking about identifying non-beneficial care when death was unavoidable, and we weren't expecting a good outcome. And good outcome is really relative, right? So, you know, somebody might be okay with an outcome where they could be with their family, they could enjoy meals with the family, maybe if they can feed themselves and they have some mobility, and other people will only accept if, you know, if they go back to work. Interestingly, you might at 20 years old before your injury say, I only accept if I go back to work, but later on be okay with, you know, seeing your kids graduate high school, or being around for, you know, family events or holidays. And so I do think that those expectations of what quality of life means are probably more dynamic than we realize. And medical ethicists have had difficulty with this concept because they, you know, if somebody fills out a living will or you know, some sort of advanced directive early in their life, that may not 100% represent what they feel like, you know, 20 years later, and that that's just something that we have to deal with as clinicians, and probably just talk to families and get a good feeling for where patients' priorities lie. And then the small possible probability of a good outcome, does that justify the cost? And that's a little bit of a philosophical and ethics question. So this was we looked at data from 2015, and I'm not going to spend a lot of time on the details of this, just to tell you that we had kind of come up with criteria based on experience, the wise old Gandalf dude, and we had said, okay, if you have a coma and loss of brainstem reflexes for greater than 24 hours and a structural lesion to explain this neurologic condition, and absence of other confounding factors, meaning it's just the neurologic injury that gives you that, then we're going to identify those patients and follow them. And we ended up looking at 100 patients, 102 patients over a number of years. And I don't know if you can read, this is just the characteristics. And they were kind of spread across the different specialties, neurology, stroke, TBI, there was subarachnoid, there, you know, it was all comers. And about 70% of these patients that met those criteria that I previously described were dead by the time that they left the hospital. And 50% of them died because we withdrew care. And we were looking at the impact of goals of care discussions. And really what we learned was that we don't do such a good job of having goals of care discussions with people across the board. We tend to talk to them about goals of care when we decide that they should have withdrawal. And that's not probably the best way of doing it. We probably need to be having these conversations earlier. And having a conversation about goals of care is not really a substitute for discussing palliative care. Like I think the two are very different. And so we learned a lot sort of about our process, and also how often the people that are dying in our units are dying because of withdrawal of life-sustaining treatments. This leads to a problem of self-fulfilling prophecy, and this is true in situations outside of medicine and outside of end-of-life discussions, for sure. This is a paper from a recent medical ethics journal that actually looks at the problem of a self-fulfilling prophecy. And I don't know if you can look at this, but on the left side here, if you have some situation, like you predict an outcome is poor, right? And that your idea about the outcome will affect the outcome. So for example, I meet with a family and I say, you know, Abuelita has an ICH and it involves her brainstem, and she
in Montana that Alan heard. But I'm also throwing in some slides pertaining to our general methodology.
Is it possible to mute him?
You know, when these very rich patients get horrible diseases, they come to us and we say, well, you're beyond the standard of care. Next thing they say,
there you go. That could have been actually quite relevant to what we were talking about. All right, so if your idea about the outcome is going to affect the outcome, then it can produce the outcome artificially. So, and that is a self-fulfilling prophecy. So if you see here, if you think that the patient's going to do poorly, and this is a true positive, then the patient will do poorly, even if you don't withdraw. If it's a false positive, then you are transforming the outcome by having the patient die, right? And when we think about our experience, we don't take that into account. If you think that the outcome is going to be good and you don't withdraw, if the outcome is good, you're correct. If you think that the outcome is going to be good and you don't withdraw and the outcome is poor, you didn't affect the outcome, right? So on the right side, with negative test results, meaning that your opinion doesn't affect the outcome, you're not transforming that outcome. And so the problem that we have with withdrawal of life support is that for a very, very long time, our opinions about the prognosis immediately affected the outcome. And so saying 70% of these people died, but you know that the majority died because we told the family they were going to die and then we withdrew care, that's not necessarily a valid evaluation of how that patient would have done if you didn't withdraw care. And that is a fundamental problem with this type of research and this type of investigation into prognosis. And the ones that we probably see it affect the most are traumatic brain injury and subarachnoid hemorrhage. But you can, any patient that has acute brain injury that's severe is really in that same bucket. This is a recent-ish paper. Dr. Hammond is a rehab physiatrist, very accomplished, and this paper followed TBI patients out to 10 years. And just what I want to point out is this is 10 years of looking at the FIM scale, I believe. So this is self-care, this is mobility, this is cognition. This is year 1. I don't know if you can see my little pointer, but on the left side of the x-axis of each of these columns is year 1 with year 10 on the right side of the x-axis. And, you know, group 4, which is the pink line at the top, they did well from year 1 and they stayed good for 10 years. Group 1, which is the blue line, they really were doing poorly at 1 year and they stayed doing poorly at 10 years, right? So those are kind of the people that if we think about in our experience, that's who we remember. And then there's these group 2 and 3s who really do have some improvement over 10 years out from TBI. This is specific to TBI. And this is on all areas. So this is in self-care, so ADLs, in mobility, ambulation, and in cognition and cognitive function. Group 3 didn't get as much from the cognitive, but group 2 got a lot of cognitive function out at like 2 and 3 years. And if you talk to parents, moms, often, they'll tell you, you know, Johnny's still getting better. And I think like for a good part of my career, I just thought it was, you know, like, oh, wishful thinking. Of course, you know, the mom sees like, you know, little things and really thinks that the person's getting better. But this is pretty objective. This is a FIM scale that's done, you know, it's a validated objective way of looking at function in different domains, cognitive, mobility, and self-care, that really do show that there are subsets of people who continue to improve way far out from their acute brain injury. And if you look at research in TBI, most of us say that, you know, that improvements or that outcome can be measured in TBI, really 9 to 12 months would be great. Like if, you know, often they do it at 6 months because of attrition and fallout from the studies, and they're worried that they're going to lose the people to follow up if they go too far out. But so 6 months is often seen, but 9 to 12 months, if you're doing research, seems, you know, is always considered to be a pretty good endpoint. And this really shows us that probably there's endpoints beyond that are really very clinically meaningful. And that's important for us to consider, right? And you know, how somebody looks at 3 months may not be representative of at all of how they're going to look down the line. Okay, so I'm going to show you a bunch of cases in the last bit. And these are all your patients, and I want you guys to tell me what you think. So this is a 53-year-old guy who has no past history. A tree branch fell on his head while he was cutting trees for work, giant tree branch. Comes in, GCS of 3, he gets some resuscitation, intubated, he starts to localize a little bit. He's got anisocoria, pupil on the left is 2, the right is 4, he's coughing. And then he has a scan that kind of looks like this. He's got a subdural and an epidural and subarachnoid, traumatic subarachnoid. He's got some tight cisterns, you can see. And he gets a hemicranie His hematomas are evacuated. He's got a little bit of contusions that blossom bilaterally. But you know, this is the scan. So and his impact score, if you go online and you look up his prognosis based on the impact scale, which is a validated methodology for taking admission criteria of TBI patients and coming up with the probability of a favorable or unfavorable outcome by the Glasgow outcome scale score. So he has a 48.6, very specific, 6-month mortality and 63.7 probability of 6-month unfavorable outcome. And I have over and over and over heard people quote the impact scale, the impact score to families at the point of 2 weeks when we're deciding trach and peg. And so I'll leave it at that. But what would you guys, oh yeah, and here's his MRI it's like probably 2 weeks out from his TBI. He's got reactive pupils and his GCS is 8 at this point. So he's 2 weeks out. So now what do you all think? Will he recover consciousness? Anybody? I don't want to have to call on you. Let's see. Anybody? Yes or no, or show of hands. I don't know if I can. I'm not allowed to ask Aham, he knows. Let's see. All right, it's quiet out there. All right, is he going to recover consciousness? Is there a way for me to look at, do you guys know how to hold up hands for this? All right. Will he do his ADLs? Maybe. Will he walk? Right? These are the things that families are asking you, right? So this is him at 18 months. Okay, so he's fishing with both hands. He got to the chair. You know, I don't know if he's a submarine pilot or whatever, but I think that he can fish at 18 months. You know, and I think that that's not always expected. He's not a super young guy. He was, you know, in his 50s and he had a bad TBI and he didn't look so great at 2 or 3 weeks, right? Okay. So early withdrawal of support is a problem for our patients. Here's another case that kind of looks at that. So this is a 66-year-old guy. He was on a bicycle at 66, which is admirable. And then he got hit by a car, GCS of 9, he deteriorated to 7. He was initially localizing weekly and then had some anisocoria, pupils 4 and 1, and his CT scan showed this big temporal contusion, multiple bilateral contusions and some traumatic subarachnoid. He's got brainstem badness here. You can kind of see subarachnoid and some what looks like some brainstem contusions. And I think most people would look at this scan and be like, oh, this looks terrible. He's 66. Like this is a bad deal. He got a hemicranie. And, you know, so you guys always do your part. You really do. You take them to the OR and you know, we give them the best shot. He had his hemicranie, he got supported. I think if you look at this imaging, you might cringe a little and say, oh, that brainstem doesn't look very happy. I'm not really sure. Day 11 MRI, the brainstem doesn't look that bad, I would say, on this FLAIR image. But he definitely has temporal contusions and his exam wasn't so hot that early. So the questions that we will ask, you know, is he going to survive? Is he going to recover consciousness? These are the questions that we ask, you know, is he going to have a trach and peg forever? So, and will he walk? So this guy ended up going out of the ICU and he was transferred to the hospitalist service on the 3rd week after TBI. And he had gotten his trach and peg already. And the very first note by the hospitalist, I looked it up last night, read PVS post TBI, he will be full care, DNR, DNI. The very first note. So first of all, you can't say he's in a vegetative state at 3 weeks post TBI. That just is an incorrect statement. You have to wait much longer before you start to talk about that. You don't know that he's going to be full care. This person has no experience in neurotrauma, yet she felt that, you know, she had sufficient experience to tell the family that this patient was going to be full care and DNR. And thankfully, we have amazing neurotrauma team that does a lot of chart searching. And I don't remember in this specific case if it was Veronica or Liesel or Ahem that found this in the chart and basically said, whoa, you know, what's going on, and kind of intervened and talked to the neurotrauma to the hospital service and said, you know, I don't think that we know this, and I don't think that I think that's too early to say. So this is this guy at 6 months. He's using a stand-up walker still with physical therapy. 6 months is not that long after this kind of TBI. And this is him having his breakfast. He's, you know, able to eat breakfast and be, you know, these are his ADLs. And it's only at 6 months. So again, this just underlines we have a problem here at Jackson, but it's not just at Jackson. This is a paper that is currently in press. Ahem Alkastrom is the first author, and the data were taken from the Florida Stroke Registry. And the purpose of the study was to really evaluate objectively the effect of all abnormalities of consciousness, impaired consciousness, and the effect of that on mortality by way of withdrawal of support. So it's that self-fulfilling prophecy that we discussed at the beginning, that if somebody is not awake and people assume that they don't have a good prognosis, they will be made DNR and aggressive support will be withdrawn, and then the patient dies. And what was found in these data are that 33% of patients with impaired consciousness will go on to die, and that the mediating factor here is withdrawal of life-sustaining treatment. And it's important. You might think of it and be like, well, no, duh, right? They're going to do badly, and so you make them DNR and you take them off. But I think it's important to recognize that you are directly affecting the outcome by doing this. Many years ago, there was a paper by Claude Hemphill out of the California Kaiser system, and he actually looked specifically at ICH, and he took patients with exactly the same age, volume of ICH, and GCS score, but that were admitted to different hospitals. One hospital had an early DNR policy and the other one didn't. And the mortality was incredibly different at the two hospitals, and the outcomes were different. If you don't limit care early, you give some people the opportunity of waking up and recovering. And I think that that's what these data really show us, is how often we are causing the outcome that we're measuring. So at Jackson, we looked at this. These are patients that were admitted to or enrolled in one of our ICH trials. And we looked at, okay, for these 16 patients, what's our mortality in it? It turned out that 44% of them were dead by the time they left the hospital. And that's compared with 32 if you look at all of the 32% of all of the Florida data, meaning that we seem to have a problem that's beyond the scope of what you see in other places in our place. And that's something that we need to address within our hospital system, and maybe look at how these patients are referred to non-neuro specialties or to palliative care. Maybe it's early. We have some sort of electronic pop-up that comes up as early as the ED in patients who are presumed to have a bad outcome, that basically offer the consultation to palliative care before the patient is even seen by neurosurgery. And that is, I think, a systemic problem, and one that needs to be addressed. So early DNR, early de-escalation, and early referral to palliative care are mediators, I think, of this increased mortality that we see in our hospital population. So here's another patient, and they don't all end up exactly the same. So this kid is 20, different from the last two that I talked to you about. He was riding his ATV, no helmet, of course. GCS of 4, pupils were 2, non-reactive on admission. He has a pretty bad looking scan. He's got a lot of skull fractures. He's got some tight-ish cisterns and traumatic subarachnoid and a contusion there. But he had a complicated hospital course. He ended up with a venous infarct and a pneumonia and a decompressive hemicrania at some point. He was in the ICU for quite a long time. And at almost 3 weeks post-injury, he had this MRI. And at this point, at 3 weeks, actually, even through 8 weeks, he had a pretty bad exam. He was definitely comatose the whole time, and he had really, really severe storming, paroxysmal sympathetic hyperactivity with tachycardia, sweating, increased tone. He looked terrible, and he would posture during this. Really, really looked bad for a long time. But you know, the scan, if you look at the scan, he's 20 years old. You know, his brainstem didn't look terrible. He does have some, you know, scattered hemorrhagic changes on the MRI. You know, so you say, okay, he's storming. He's a 6T at 10 weeks. You know, how is this guy going to do? His mom is asking, you know, is he going to recover? Is he going to wake up? You know, how's he going to be? So this is him at 3 months.
Open your eyes, open your eyes, open your eyes. Smile.
So he's starting to follow a little bit, but you know, it's pretty
Your tongue.
pretty
Come on,
disabled.
let me see your tongue.
And this is him at a year. So he's super dysarthric. He's got spastic speech. He's obviously very disabled, right? You know, this is a 20-year-old guy who I don't think his scan was bad, but it wasn't like catastrophic bad. So I think it's really difficult to just look at a scan and an age and decide what you're going to tell a family is going to be the outcome. On the other hand, he did recover consciousness, right? So what mom wants to know is he going to wake up? And I think you can say, yeah, he woke up. He woke up, and he's definitely, you know, disabled. So I think one of the things, you know, in our area that we would like to develop more is research into how we can specifically look at a patient and determine what outcome might be or what features of outcome we can predict. This is like my pride slide from, we have EpiBios is one of the neurotrauma research studies that we are involved in. And these are all of the different groups across the country and internationally enrolling studies. And I just want you to see, and I know Daniel and Aham are on this call, and the two of them have been instrumental in helping us enroll. But Paul Vespa at UCLA is the PI. So that's why these are little Vespas to show, but we are in first place here. We've enrolled more than the home institution of UCLA and UC Davis. And we're way ahead of all these people like MGH and Yale and Cincinnati and UPMC, which I love. So anyway, so our research program is growing. It's vital. We're enrolling a lot of patients. We're studying these TBI patients. And one of the things that we're interested in looking at is, can we pick up people who will wake up later? And there's been a lot of research on this. This is from 10 years ago in Lancet. These are EEG studies on patients that are pretty far out from their trauma, like, you know, years sometimes. And they're doing EEG work to see if they can pick up patients who have the ability to cognitively follow directions. So if you tell them to do something, they may or may not do it behaviorally, but their EEG will change. And that will identify people who are processing information more than you can tell. So this research has been going on for a while. And the idea behind this type of research on recovery of consciousness is that you can use multidimensional assessments of consciousness to identify people who have a disconnection between their motor behavior and their cognitive function. So that's your cognitive motor dissociation. So what you see on this little table is over here is motor function, and the Y and the X is cognitive function. So people who fully recover after their brain injury are up here in this right-hand corner, where they have full motor recovery and full cognitive function. People in coma are down here in the left-hand corner, right? And what we see is that minimally conscious, they may not have much in the behavior, but they're starting to recover cognition. So one of the questions is, how do you identify patients who have cognition but can't behave? Because the way that we usually measure recovery is through a behavioral scale, the Glasgow Coma scale, the Glasgow Outcome scale. And so other ways of looking at this, this is the Coma recovery scale that we use to look at the behavioral recovery, and it looks at the visual field, tracking, motor function, the ability to follow directions, the ability to attend to something or fix on an object. So it's a very much more detailed way of looking at recovery of consciousness. And many groups, the group there's a group in Cambridge, and then at Columbia Presbyterian, where Ames came from, have been looking at this with EEG. And one of the things that you can do is compare normal control EEG during commands to patients in coma. And what you identify is that there's a subset of patients who EEG changes consistently with what you would see in healthy controls when they are asked to do things like open and close your hand. And this is an EEG at the top. And then at the bottom, you can see the peach color are the healthy controls that have clear directional changes in EEG with requests for command following. And the blue is are patients who are injured and do have some changes that are in the same pattern as the healthy controls. And then that black line down the middle are patients who are injured and don't have any changes. So the whole idea is, can we identify this subgroup of people who have cognitive function, but you just can't see it when you evaluate them behaviorally? And this is a predictive approach to determining recovery of consciousness. So we have a lot of ways of saying, I don't think your loved one will recover consciousness. If your brainstem is completely has a structural lesion in the middle of it, or you have refractory status, or you have some other horrible prognostic factor, we know that your chances of recovering consciousness are not good. But we don't have very many ways of looking at positive predictors. So if you do have this, your chances of recovery are good. And that's really what we're looking for. So there's multiple studies that are in variable degrees of age, I guess, of being carried out in here, and also in collaboration with other centers. Reconfig is looking at EEG changes in unresponsive patients with intracranial hemorrhage. EBC is with TBI patients. Musica is in patients who I think have also TBI, and we're looking at their differential responses to music and language. And then covert tracking is looking at eye movements. And these are all, the PI for this is Dr. Alkashroom. That's why his picture is up there. And you see him like this in the unit a lot, even when he's not on call. And you can see this patient has a cap on. It's a high density EEG. They also have earbuds in where we play either sentences or music or a story to try to see if we can see changes in the EEG in these patients who are behaviorally comatose. So what we're looking for is somebody who behaviorally does not show reaction or interaction with their environment, but who is showing cognitive changes based on the EEG. This is I don't know if you guys can see this on the outside, but this is the plan for an ongoing study named Musica, which is looking at TBI patients who are unresponsive after TBI. We're looking at the Coma recovery scale to gauge when they behaviorally show evidence of recovery of consciousness, and then we're looking at their EEG in response to music being played, and also to language. And so this is sort of a diagram over here in the right upper quadrant of cohesiveness of the coherence of the EEG, meaning that if an area of the brain is activated in a meaningful or organized fashion, you can see that there is coherence between regions on usually in one area of the brain in response to that stimulus. And so we're looking for organized response to music or to language. And we can see that in the healthy controls, and we are comparing that in the patients who are comatose. And I think he studied, I think we have a fair number of patients. The data were from 5 that I'm showing you here. And there are some patients who show organized reaction to either speech or music, even when they are unresponsive behaviorally. And I think that's just super interesting and super exciting. If we can identify with these studies patients who have covert consciousness, that will go a long way in helping us inform our prognosis for when we talk to families. I mean, we're not, the data are not there yet. We have a long way to go, but these are really important first steps and studies that hopefully will be funded and be going forward in these next couple of years. So here is a patient that was enrolled in Reconfig. So she's 66, she has hypertension, she has an ICH that you see here on the left. And this is her MRI to the right. So she has, it's mostly left hemisphere. She's got hypertensive changes on her MRI. And she's got a fair size hematoma. And the question is, will she survive? I think most of us would agree that she probably will survive unless something unexpected happens. Will she walk? I think at 66, most people would not tell the family that she would walk. This is her at 6 months. It says rehab in Miami, right? So I think it's important for us to recognize that there's a lot that we don't know about, how people recover, even at older ages. I mean, if you read the TBI literature, 45 is supposed to be like the pinnacle, and then it's all downhill from there. So this lady was 66. I guess it gives me hope as time goes on. This is a slide just explaining another one of Ames studies that we're doing in the ICU. This is using tracking glasses that can look at objectively measure eye movements. Again, you're taking patients who are unresponsive, you're putting glasses on them, and you're giving them visual stimuli. It can be a mirror, it can be an OK-in strip, and I think there's like an orange ball. At the top right is what a healthy control looks like when you look at the tracking. And these are little dots, the orange are little dots. And this part, you can see there's clearly a directional movement of the eyes with the OK-in strip. It eventually goes away because people can suppress it when they're awake. Down here at the bottom, you can see healthy subjects when they're shown a mirror, they track in a pretty consistent way back and forth with the mirror. The TBI subjects that don't track kind of have a cloud in the middle of the screen that is not necessarily organized. But in 3 of our acute brain injury patients, we did find that they were able to track, so have covert tracking, even when you couldn't appreciate that clinically. And part of this study is to do surveys of the nurses and the physicians that are taking care of the patients and ask them, do you think this person's tracking? So I have a couple more here just to kind of make my point. This is, or actually I think maybe he's the last one. This is a young guy who's a physician actually, that fell and had a pretty bad head injury for a ground level fall, I would say. He had this initial CT, his GCS was 4, he was extensor posturing, he had anisocoria and this large hematoma. And he has really tight cisterns, you can see on admission. He was taken to the OR, he got a hemicraniectomy and a decompression. And in the, what I heard was, we have a patient coming up, he's in status. He's having seizures in recovery. And when we saw this guy, we put an EEG on him, and really it wasn't seizures. He was just so profoundly posturing, spontaneously posturing and extending that he looked like he was having tonic seizures. An EVD was placed and ICPs went up to 30 with these events. So he had a pretty significant brain injury, both clinically and image-wise. You know, he had his age going for him. Pupils got better after the decompression. And this is his MRI, 10 days. So you can see, you know, here, there's some pretty classic signs of axonal injury, of traumatic axonal injury. There's changes in the midbrain, in the corpus callosum here, and you can see the long tracts are affected on both sides coming down. And this is a T2 with, you can see the signal changes in these white matter tracts. And this is really typical of traumatic axonal injury. And classically, people who have DAI are thought to have a very poor prognosis, that it takes them a very long time to wake up. They're extremely disabled. And you know, for a long time, we thought that they were all going to die or that they were never going to wake up. I think as we see these people more and more, we realize that, you know, they can have an outcome. They often have a lot of disability, but it often takes them a long time to wake up. There's probably some dynamic aspects to traumatic axonal injury that we haven't fully appreciated. And you know, I think it's an area ripe for more research. But, you know, the question for his wife was, you know, that his wife had was, is he going to wake up? Because he looked pretty bad early on. And even after his ICPs were controlled and all the monitors were out, he still did not look very good and had storming and really wasn't showing us that he was recovering. Is he ever going to wake up? Will he wake up in 3 months? Will he wake up in 6 months? And, you know, at this point, we kind of said, well, we don't know. We're going to trach and peg him and we're going to support him and see, you know, what happens. So this is him like really early, like 3 weeks, actually. He woke up pretty quickly. He's sitting here up on the floor. He's trached. He still has his feeding tube, you can see, but he is actually awake and he's interactive. He totally understood what we were talking to him about. Let's see if we have a little of this.
Can you hold up your arm for me? Hold up your arm. There you go. Good.
So he was able to follow directions. He had a passing mirror valve, but he wasn't really able to phonate quite yet. But this is super early. This is 3 weeks. But I think most people wouldn't have expected this degree of cognitive or motor recovery so early in somebody that had significant DAI on their imaging. And I show you these examples just to show you, just to try to make my point that imaging isn't everything, the impact score isn't everything, experience isn't everything. And we have a really, really huge need for more detailed patient-focused research that will be able to allow us to find positive predictors of recovery of consciousness and also recovery of motor function eventually. So I would leave you with the ideas that there's a lot yet to discover about recovery of consciousness. That early limitation of treatment leads to a self-fulfilling prophecy and prevents valid outcome assessment. And that is really all of our jobs, to be aware of that and to try to avoid that and to be the humble optimist like Dr. Bullock. Okay, that is all I have, and you have, I think, 3 minutes left. Are there any questions?
Hi,
Hey, Christy. Oh,
Oh,
go ahead.
sorry, you first. Oh, thanks.
No,
Hi, Christy, it's Ron. So, thank you very much for your review of our, flawed and retrospective and not very large study from a few years ago. And I really like your idea that, as we get more experienced in practice, our level of certainty about our knowledge and predictions actually goes down instead of up, right? The opposite of what you'd expect. It's all of the patients whose good outcomes you showed us actually probably would have been not excluded, but the conclusions of that very limited study. The young people with good outcomes, we actually found that the few patients who regained consciousness were young trauma patients. I think that is consistent maybe with what we saw. I wonder now, with another 6 years of data, and patients who care was not withdrawn, I wonder if it's time to revisit, those very simple criteria, even retrospectively, because I think there's going to be a lot of patients now who may have fit those criteria, but who got aggressive care, and I think legitimately so, with the expectation that a significant minority would have good outcomes. I don't know if it might be worth revisiting those criteria.
Sure, I completely agree. And I think my point with that study, it really wasn't about the outcome. It was more about the effect of withdrawal of life support on the outcome, like how often we do this. And I think that is the example that I was trying to make with that is how the problem of self-fulfilling prophecy is inherent in our process. And it isn't just us, and it isn't just the study, it's the way that we all practice medicine, and it's a really tough thing to get around. I agree with you, that maybe with some of these newer techniques, we can come up with criteria that will be very patient specific and that would really be very helpful and useful to determine which direction we should take early on. Thank you.
Hey, Christy, enjoyed the talk very much. On the parallel to that self-fulfilling prophecy, the reverse, I guess, also happens. I don't know what to call it. You could call it self-fulfilling validation. Like these studies that they did on hemicraniectomies for stroke, then they asked the family, do you regret your decision? And of course, most of them don't. And so not only is there a prospective bias in us physicians wanting a patient to fit what we want them to fit, and then in reverse, you adapt to the decisions you've taken early on. Who's going to say, very few will say, that was a terrible decision, I wish he was dead. We don't, families do, correct? They don't do that.
Right.
So the bias is in both directions, interestingly, I think.
Completely agree. And that's actually why I think it's important to have objective measures like the FIM score, right? So if you look at like somebody's ability to get dressed or eat a sandwich or, walk, that I think is probably a better measure than, hey, aren't you glad you're alive today to sit in the chair and watch Oprah?
Right.
Yeah.
Thank you.
Yeah. Thank you.
Christy, well, good morning. The question is, Aldo, how many times have patients that have come out of these profound coma tell you that they have memories of what has been said around them and what has happened around them? Because I have had that experience with several patients.
So it's variable. I would say the great majority don't ever remember me or the ICU. They have antegrade and retrograde loss of memory around their injury most of the time. There are some patients who recover some consciousness in the ICU and then have kind of prolonged stays because of medical complications like pneumonias or renal failure or something else. And they often have like very profound delusions about the treatment. So like that the ventilator was a snake, or people came in, like now with everybody wearing all this garb on their head, that like there were aliens in the room, or that there was, you know, somebody that was doing something to them. It's usually not a very comforting memory. So I'm usually happy if they don't remember anything. It's definitely something to keep in mind and to try to help. There's a lot of research now on the post-ICU syndrome that's actually measuring PTSD in these patients and looking at ways of minimizing that. And so that's actually ongoing research that's looking specifically in neuro ICU patients at how often they have PTSD or they have you know, these very vivid memories.
If I want to tell you this because we have to be careful about the comments we make in front of the patients when we do rounds on them and they are supposedly unconscious.
Totally agree. And the more that we do these studies, like these EEG studies or tracking studies, for me, I really think that we don't know what's going on in there. And there are people who can process information way beyond what we can appreciate just doing a simple, you know, clinical exam and a GCS.
Hi, Christy.
Hi, Joe.
Excellent talk. Thank you very much.
Yeah.
One very important one very important point, and I have the feeling is worth to highlight, is that after TBI we need time, and people don't have the patience to wait. The families, the colleagues, that we need time. For example, Damien and Dr. Jagdar, they did a beautiful review on DBS for disorders of consciousness, and they are not even accepted in the more serious protocols in the first year after TBI. So for you to deem the patient is in persistent vegetative state or so. And this is the most difficult part because we want to move fast. The colleagues, the palliative care doesn't help us typically with that. They don't have the patience. So this is I enjoy very much that the message we need to leave is that they need time to recover, especially the patients that are not young. They need more time than usual. What can help us to buy this time are those algorithms. I just sent a link in the chat. The UPMC just developed a very refined CT algorithm that can be done even in the very acute phase of the care to predict the outcome. Because we had the TIs previously that we would try to implement, but they are hard because they require a new software. And so remember, we spoke with the neuroradiology department to have these 20 areas of interest in the DTI analysis. It's costful, it's complicated. So maybe an alternative would be those CT-based protocols to analyze and to correlate the prognosis.
Yeah, and I think these next, 10, 20 years are going to be really exciting as we have more and more functional data to actually correlate with our static data, like imaging data, and try and put it together specifically for a patient. And that's really the future, is patient-centered prediction or patient-centered care of saying this patient that's in front of me has
individualized.
That's how I think. And I have to say it again, my hat's off to the neurotrauma fellows, to Veronica, to Ahem, for really following these patients and being their protectors and making sure that they have the best chance of making it through their acute hospitalization to be able to recover later.